Hello. Hello, everyone. Can you hear me? Welcome to Coffee with Lilly. Nice to see you. Bankole, hi. How are you? Can you wave? Excellent, excellent. Nice to see everybody. Hi, Megan. Hi, Dr. Hamid. How are you right now? Excellent. Hello. How are you, Dr. Hamid?
Hey, how are you?
Nice to see you.
Yeah, nice to see you too. Long time.
Long time, We're just trying to like have people join us and everything. Listen to
Okay.
our theme song.
Oh, the theme song. I didn't realize there was a theme song.
Around the world.
Okay.
But I know that you've been through traffic. You were on call last night. So hopefully as people start to like gather in and everything will start. Wow. What case did you work on last night?
We had someone that was bleeding, gastrointestinal bleed,
Wow.
and then I had a meeting in Ogun State this morning at 10 a.m. I left my house at 8 a.m. and I got back home at 5 a.m. The meeting lasted 30 minutes.
Oh, okay. Don't you just love that? Don't you just love that? And so up all night, because I was up like 3 a.m. my time. So up all night, was it a bleed from an ulcer?
Yes, I bleed from an ulcer.
Wow. So you did all that, and then because you live in Ikoyi, just so people can understand, right? So
Yeah,
Ikoyi all the
yeah.
way to for a 30-minute meeting.
Yes, yes, yes.
Would it be too nosy if I asked why it couldn't be done over the phone?
It was a it was a site assessment, so I had to physically go there. But yeah, that so we went through the Lagos Ibadan Expressway to get there, and coming
Okay.
back we went through some forests through Ikorodu
Okay.
to come back and talk about the worst roads you'd ever seen.
I know.
It was not fun.
I hear, right? Not fun. Sleepy. You can't really sleep on those Lagos roads either, right? Because
Oh
you
no,
need to know if you need to jump out of the car, really
absolutely.
quickly, really quickly.
Yes.
But we, but we have about a few people with us now, so I'll just give you an
Okay.
introduction. So, welcome to Coffee with Lily. My name is Dr. Lillian Iboma. I'm a breast radiologist by trade. I'm the founder of Lillywomen's Health, where we run a holistic women's program. Our primary focus is on breast care, but we pretty much do anything that relates to women's health, lifestyle, wellness, any issues. So on Coffee with Lily, our goal here is to spill the beans, let's crack it all open. Let's be real, authentic, talk about the things that affect us as people, as women, as human beings. On today's show, I bring with you um, a highly respected colleague of mine. His name is Dr. Hamid Hinalolo. Uh, amazing, amazing credentials. Went to University of Maryland for his medical degree in the U.S. Trained for interventional radiology at University of Pennsylvania, which is a significant, amazing institution. It's an Ivy League institution. He founded RadAid Nigeria. So RadAid is an organization that really had this vision to take radiology and imaging, which a lot of people always felt was never possible to go to low-income communities. So for years and years, places like Nigeria, there was no such thing as imaging. Like Mercure was like our biggest claim to fame,
Hmm.
and we're not going to talk about that, but it wasn't even, by us. It was, sent to us for people who realized this was like a virgin place. So Mercure was like the only thing anybody knew about imaging. So it's like if you had a gastric bleed, like what Dr. Hamid was treating last night, you probably would die. It doesn't matter if you were 30, if you're 20, if you're 50, you would die because you didn't have those services. So the founder of RadAid wanted us to see how we could, create structures and be able to actually take imaging to the world, to the remaining billions of people on the planet. So Dr. Hamid founded the RadAid section of Nigeria. And as we all know, anything that you're setting up in Nigeria is amazing, but amazingly difficult. So he took it
Yes.
upon himself to do like a country report. It's something that I wanted to do, but I was like, oh my goodness, So when I saw that he did it, I was like, yes, man after my own heart. So, from there, he's brought different specialists to different institutions in Nigeria. I know he does a lot of things in Ibadan, Ogun
Hmm.
State, just trying to see how we can create a better, robust health ecosystem, not just because when you get to Nigeria, you find it's not just about radiology. You
Correct.
find that you really have to tie in an ecosystem. So what really, really makes me respect you even more, Dr. Hamid, is the fact that you finish your training, you can make hundreds and hundreds of thousands of dollars, but because your heart and your mind, your passion, everything is at home, you took your family and two young children. I think your kids are less than three, right?
4 and
And
5 now.
4 and 5 now, right? And at that time, they were like 3 years old, and you moved everybody to Nigeria,
Correct.
and trying to
Uh,
build an
Probably
interventional
not the
radiology.
smartest thing I've ever done, right?
Do you know, I know we're the two crazy people, but
Yeah, yeah.
especially after you like do a gastric bleed, nobody really thanks you for it, right? Nobody really
Hmm.
pays you for it either. Then you drive to
Hmm.
Ogun State to do a site assessment because it looks like you're probably trying to help to build something again to serve the
Correct.
people. But it feels like a thankless job. But the truth is, Nigerian patients are worth it, like we like to say it, and that's just what we do. So, guys, we have an amazing doctor here. He puts his mouth, where his heart is. He puts his mouth, money, time, everything to the things that he says. So we're going to talk about fibroids and beyond. Like a big service he does do is fibroids, which we know affects Black women predominantly and disproportionately. But there's just so many other things that you're about that I really would love to share with the audience. So just I'll let you take it away. So Dr. Hamid, tell us about yourself and your journey so far.
Yeah, so as Lillian said, my name's Hamed Lillywomen. I'm a vascular and interventional radiologist. And, people usually ask exactly what is vascular and interventional radiology. It's basically, if you look at diagnostic radiology, we use CT scans, MRIs, X-rays to basically diagnose diseases. The field of interventional radiology kind of propped up from radiology about 25 years ago, where we figured out that if we could diagnose diseases, we could also treat them with imaging. So we started doing things with wires and catheters without cutting people open and finding our way into places in the body that surgeons used to have to cut people open to get to. And we found out we could actually do quite a bit of stuff without cutting people open. And excuse me, and the field of interventional radiology evolved from that. And now, we're kind of the focal point in most hospitals in the Western world. They see radiology and they see interventional radiology. We're problem solvers and we're kind of the doctor's doctor because every doctor relies on us to be able to help take care of their patients. I've always had a passion of bringing a field to Nigeria that wasn't really existent in Nigeria. Interventional radiology obviously requires a lot of capital expense and also a lot of effort, and also doing something like this here in Nigeria that's not
Hmm.
mainstream
Hmm.
also requires a lot of guts. But my heart has always been home, as Lillian said, and I always knew what I wanted to do, and I was happy enough or stupid enough to leave all my life in America and come to Nigeria. I mean, I started out first of all, coming to Nigeria every 6 weeks and offering services. But I noticed more and more every time I would come, I would offer more and more patient services. And it came to a point where every time I would go back to America, I get called about a patient. And when I told the doctor who was calling me or the patient who was calling me that I just left Nigeria, the question was always, what do we do now? And that was always a big, a big weight to carry as to what do we do now, because in a lot of situations where the only option available in interventional radiology. And I started doing the math a little bit. I knew that if I give up my income in America, I could start a business here in Nigeria and still kind of find a way to make it up. And the same, do a good social service to build a service in a country that never been there before, and also build a business doing that. And that's what we've done. So we've done that with interventional radiology. Lillian also contributes to the other business that we have. It's called Accurate Radiology, which is a subspecialty radiology service that reads diagnostic imaging for multiple centers in Lagos and Abuja now. And what we offer is, the field of radiology has become so complex where some radiologists are completely focused on just reading the breast and breast
Hmm.
imaging, like Lillian is. Some radiologists are focused on brain imaging. Some radiologists are focused on chest or abdominal imaging. And That's kind of what the standard is in the world now. And that's what we started offering Nigerian patients is that subspecialty radiology services with accurate radiology. And we've grown tremendously over a very short period of time. I mean, we've not been around for a year, but our volumes continue and continue to climb. And we have more
Mm-hmm.
hospitals that are looking to come on the service now. So it's been a big journey so far. You know, we
Mm-hmm.
obviously still have to let everybody know what we can do in interventional radiology, like services like fibroid embolization, like Lillian was talking about, and we have a long way to go, but we certainly come a long way already.
Yeah, no, no, definitely, definitely. So before we kind of like delve into like the whole topic of the fibroids, how have you
Mhm.
found? Because the thing is, when you do like a SWOT analysis, when you look at radiology, right, the barrier to entry is so high because it's so expensive. So not only do you have to deal with the equipment procurement, then you now also have to have specialization of who's going to actually operate it. So a lot of
Mhm.
times you kind of need private businesses to, to give you this back end, but then as well, we need I don't like talking about this government intervention all the time, but we kind of need, whether it's like their support in terms of like, hey, a nod of I support this person. Like, how are you finding, the integration of
So,
private government to kind of facilitate things, so to speak?
so we have not focused on the government at all.
Mm-hmm.
I've basically made the decision that all of my work with the government will be pro bono. Basically, if I go to a public
Nice.
hospital or I collaborate with a government entity, if you expect to basically create a business from that, you just be frustrated. And then
Mm-hmm.
talking about the capex side of business, we have focused on running a very, very lean business model. With
Mm-hmm.
interventional radiology, for example, it takes about $3 million or so to set up an IR suite, right? To have
Right.
CT, a fluoroscopy, all
Yeah.
sorry, you do a survey uh, of the fluoroscopy suites or the angio suites in Lagos, for example. And that's what I did is I did a survey of them and looked at the utilization of these places. And I noticed the
Mm-hmm.
utilization was less than 10%,
Low. Yeah. Very
right? It was
low.
very low because all they were doing were basically cardiac interventions, right? So for me to bring an investment of $3 million or so into a situation like that's probably the dumbest thing you could ever do, right?
Mm-hmm.
So what did
Mm-hmm.
I do? I instead leaned on the capital investment that was already here and
Right.
partnered with the folks that already made that capital investment.
Mm-hmm.
And basically, and that's how we started. So we just came up with a sharing formula. We will use your equipment, we will use your hospital, and we came up with a sharing formula that's worked for everyone. So we stayed lean on that side.
Nice.
And then when it came to the diagnostic radiology, as you know, we own no equipment at all, or we
Mm-hmm.
own our professional services, which
Right.
are basically human beings. And we don't own
Mm-hmm.
any human beings, by the way. I mean, every doctor that works with us works
Yeah.
for themselves, right?
Exactly.
So we've also stayed lean on that end because we didn't want to go into the market, getting
Start
into the
hiring.
big cap capex,
Mm-hmm.
and we started the professional services. And so far, that's working out for us. We are talking about going into the capital expenditure market into getting our own facilities soon, or collaborating into, getting a CT scan at a hospital. But that's kind of down the road. Again, we prefer to kind of grow organically over time and not
Exactly.
kind of rush into the market because we've seen people really lose a lot of money in this market.
Because
You
it's like I
know,
always say,
uh,
Lagos, Nigeria is a very complex place where there's quote unquote
yes,
this
yes,
money in Nigeria, there's this volume in Nigeria,
yes,
but then the psychographics of the people is very interesting. So you
abs-
really need to like it has to be organic. They really have to number one trust you. Then you have
absolutely.
to understand how they like to spend.
Hmm.
Then you have to understand what they determine to be value that they would like
Yes,
to
yes.
pay for, and that's just on the consumer side. But then you have the vendors. It's you see the need. The need is clearly well, it's almost like 150% need. So you think if they
Hmm.
build it, they will come. Like Nigeria is like that extreme opposite of if they build it, they will come. It's
Yeah,
mind
it doesn't
blowing.
exactly work that way. I mean, I'm sure one of our colleagues bought a pretty big CT scanner, 640 slide CT scanner into
Yeah.
the market, state of the art, was supposed to be the best thing that's ever come into the market, but, didn't work out.
Yeah, you
Um,
would think, I mean, it's like the best of the best, cream of the crop, and yet zero utilization. And
Absolutely.
you wonder why, and people don't want to. And that's another thing. As we start to get closer to talking about clinical services, how are you finding people's value on the services that you're bringing? Because you essentially, like what Hamid does is the things that either people say you cannot operate on, the things
Hmm.
that people will die from because to even get into the operating room, sometimes you have to stabilize a patient enough to even be able to operate on them. So inoperable things or people that need to be stabilized before they go into surgery, or things that just need to be stopped fast, like bleeding, for instance. So here it is, I think, in talking to you, there's only one other doctor who is trained in a European country that's based in Maiduguri that does what you do. If I had to kind of like just be liberal, I think it's about maybe three people who do what you do, and now you've brought
Um,
your services pretty much 24/7 in terms of like the interventional, not just like cardiology.
so when you talk about
Go ahead.
complex interventional radiology in Nigeria, I'm probably the only one that offers interventional radiology at a
Exactly.
very
I was just trying
complex
to be
level
super modest. Yeah.
in the country. But we do collaborate with other folks
Mm-hmm.
all over the country to make sure that these services do grow and there is competence. But again, Nigeria is a country where people kind of want to just say, hey, can you show me one so I could go do one? And I'm not really
Hmm.
interested in that because, it takes a lot of training, obviously, to be able to do this. And you don't want people to say, I was trained by Hamed and go kill people, you know?
Right.
So
Because it's
you
more
also
than
have to
just
be
doing it,
very,
right? It's not
yes,
just like
yes,
see one,
correct.
teach one, do one business, right?
Yeah,
There's a lot of back end
correct,
stuff. You do something on a patient, you still have to follow them up. There's
correct.
systems that have to be in place
Yes,
and also quality. But how are you
yes.
finding patients' awareness of what you're doing? Like,
So
is the public aware of what you're doing and do they value it, would you say?
yeah, so the awareness is definitely growing. Obviously, even doctors don't know what interventional radiology is. So every time I
Mm-hmm.
go give a talk and I show the breadth of what we could do, I mean, their eyes are just open, like, oh, you could do that, and you could do that, and you could do that. And then through that next month, you just keep getting calls from one doctor or the other saying, oh man, I saw you give this talk, and I have this patient. So the first thing,
Mm-hmm.
as you said, is awareness because people don't know what's possible, right?
Right.
Say, for example, liver cancer. So
Mm-hmm.
no one in the country was treating patients with liver cancer with transarterial chemoembolization. And as we know, that's really the only treatment
Right.
for the early treatment for liver cancer apart from
Mm-hmm.
transplant, right? A few patients qualify for surgery. But in Nigeria, what we've seen is most patients with liver cancer do not qualify for surgery. The only treatment they can get is transarterial chemoembolization. So now think about all of those patients that had liver cancer in Nigeria for a long period of time, for the last, say, 20 years. You think about
Mm-hmm.
what happened to them. Some of them made it to India, right, to get
Wow.
treated. And the ones that didn't make it to India were basically left for dead. They did not get any therapy. So people are now starting to get aware that, like, for example, a patient had a ruptured liver cancer from Akure and was transferred to me the next day. I embolized him the next day. And that awareness is now there that there's a place, that's not
Right.
too far away that these patients can get care. And now think about a period like COVID, right? Where no one could get out
Mm-hmm.
of the country to do
Mm-hmm.
anything, right? And no one could go to India, no one could go to any other countries they used to go to. And we're really here to, make sure that, the services are available at all times, right? Things like gastrointestinal bleeding. There were no other there was no treatment for gastrointestinal bleeding other than endoscopy. And as you know, in our world and the Western world in America, a lot of times the gastroenterologist goes to scope a patient, and what do they do next? They call the interventional radiologist and says, "Can you
Exactly.
come employize this patient?" So
Mm-hmm.
just think about all those services that were not available. But when you talk about people appreciating the service, I think it's completely valued, right? Doctors and patients alike completely value the service just because, as I said, there were no options before, and there is an option
Right.
now. They know that they could send their patient to somebody who could take care of them now. So the service is very well appreciated.
And I hate to say this, and I think a lot of what you do, because unfortunately, I think everyone knows that in our culture, we don't like to prevent. We maybe even like to diagnose, but for the
Hmm.
most part, we want to treat. And people don't really pay attention until things have gotten really bad. So a
Correct.
lot of times, though, a lot of your patients are patients with serious pain points. So like the liver tumors needing that chemoembolization, they're having jaundice, they're having like liver failure. I mean, it's so complicated. So they're happy to even almost just pay for your service. So then let's move
Correct.
into this the service of women's health and fibroids. So I mean, I think almost any Nigerian, any woman, any black woman, pretty much to the age of 30 starts to understand fibroids. Like either you have a friend who's had fibroids, or your mom, or you yourself, your aunt. I've had personal stories of, the only treatment for fibroids that I knew, 10, 15 years old, was that they're going to take your uterus out. You're going to have a hysterectomy, or you have this, symptoms of like menstruation. I had an aunt who I thought for the longest part was pregnant, and I was waiting for her baby to be born for like 5 years. You know what I mean? Like as a kid, right? You're just like, why is her stomach always so big? And then the complaint of the pain, and then during her periods, it was like shut down, right, for the whole week
Hmm.
because the bleeding was just too much. And then of course anemia, things that come along with it. Then I think the most painful, like from my experience clinically, is when, we're doing a service for a patient who's trying to have children, right? And that constant miscarriage because they have a fibroid that's located, in a submucosal region, which is kind of, you know what I mean? It's like a double-edged sword, so to speak.
Right.
So you have a woman who would get pregnant, and then once the baby gets to a certain point, because guess what? The baby's growing and the fibroids are growing at the same
Yes.
time.
Right.
So, it could be so debilitating. Then the people who have like, pain with sex. So with the pain with sex, heavy menstrual bleeding, body disfigurement, bloating and enlargement, it can really impact people's relationships. So I kind of also have a picture here, guys, just to, show you the different types of fibroids. I don't know if this is kind of projecting. So that way, Hamid can like really go into what he does, what he can and can do. So this is the uterus here. So most fibroids are like in the intramural, meaning in the muscle of the uterus itself. So this is the ovaries. Just don't let that distract you. Then you have some fibroids that would grow on what we call the subserosal layer, kind of like outside of the uterus. So that's kind of like what would cause some disfigurement, depending on how big they get. Then the ones that are like really rare but very annoying, cause a lot of problems, are the one on the submucosal area right there. So you can imagine a baby, embryo, a baby that's planted here, and this fibroid starts to get really, really big. It can really cause a miscarriage. And then some people also have it along the cervix. So depending on where this is and the arterial supply and things like that is when we now call Dr. Hamid and say, Dr. Hamid, please, I'm bleeding too much. I want to have a baby. I have a fibroid as this size, in my body. What can you do for me? So I'll let you
So,
take it away.
so as Lillian talked about, so fibroids are, or the other name for fibroids are called leiomyomas,
Mm-hmm.
basically benign smooth muscle tumors that occur in women of reproductive age. And unfortunately, especially for Black women, because we're so fertile, fibroids kind of go gangster in Black women.
Pretty much, right? I like
So
that. You go
yeah,
gangster.
so especially a lot of women in Nigeria, there's a lot of fibroids in Nigeria. But the first thing I always talk about is, fibroids are benign, meaning, it's not cancer, right? And it's the most common benign tumor of the female genital urinary tract. Um, but I always say something too is not all women with fibroids need to be treated. And it's very
Mm-hmm.
important to say that at first is, we don't want to go around, scanning every woman in Nigeria and asking, do you have fibroids? You should definitely come get treated. And there are some practices like that out there where, fibroid is
Mm-hmm.
identified and they want to treat it. I firmly believe, only women who are symptomatic from their fibroids should be treated. And I profess that to all of my patients.
I agree with you.
Now,
Mm-hmm.
as far as, the symptoms from fibroids, a lot of women, unfortunately, um, present to us with a lot of bleeding. They're just bleeding so much that it's embarrassing. They cannot go out during their menstrual cycles. It's called menorrhagia. Some women actually wear diapers or
Oh, that's
Pampers,
sad.
babies' diapers, because they're bleeding so much. Some women cannot go out at all just because they sit down and they're soaked with blood so it's just embarrassing. And
Mm-hmm.
for 10 days sometimes some women bleed. So you hear some of these stories and it just really hits you that you have something there that is causing you so much trouble, and there's definitely something we could do for it. So there are definitely different treatments available for fibroids, right? The biggest treatments that were always available in Nigeria was surgery, either a
Mm-hmm.
myomectomy or a hysterectomy. A myomectomy is when you go in and you just cut out the fibroids and leave the uterus in place, while a hysterectomy is basically when you take out your uterus completely, right?
Mm-hmm.
In interventional radiology, we have a treatment called uterine fibroid embolization, which was created about 25 to 30 years ago, and it's been done for that long um, in America and Europe. And what fibroid embolization is essentially a procedure where we go into the artery either in the wrist or the artery
Mm-hmm.
in the groin. And a lot of people ask me, how do you get to my uterus from my wrist? Well, there are vessels that are connected all throughout your body. So if I put a catheter in your wrist, I could find my way through the X-ray machine all the way into the vessel that's feeding the uterus. So I have a lot of women who I'm, kind of operating through the wrist, and they're talking to me the whole time and looking at that screen and asking me what I'm doing. So essentially, what we want to do is basically go put a catheter in the vessel that's feeding the uterus, which is called the uterine artery. There's one on the right and one on the left. And once we get into the artery that's feeding the uterus, we inject it with a dye called contrast, the same dye they give you when you go get a CT scan
Mm-hmm.
in the hospital. And when we identify that artery, we basically see that the artery is feeding a lot of fibroids in a woman with fibroids. And following catheterization of that main vessel, we also put in something called a microcatheter, where we go in very, very deep into the artery that's feeding the fibroids, and then we deposit particles. And these particles are like these tiny plastic particles. They're like sizes of a grain of sand. And the only
Mm-hmm.
function of those particles are essentially to block off blood flow to the fibroids. If you think about fibroids, why do they bleed? They bleed because they love blood. They basically suck up all the blood within the uterus, and they kind of attract that blood flow. So if you are able to block off that blood flow, what happens is the fibroids shrink and they die. And this has been proven over and over nearly 30 years now, that we could do this without cutting a woman open or,
Mm-hmm.
taking out their uterus. So you see more and more women getting educated about fibroid embolization and choosing not to go to surgery and choosing fibroid embolization. But again, fibroid embolization is not for every woman, which is why
Right.
every woman's evaluation is important, which is why we also collaborate with gynecologists to make sure that we're treating the right people with
Mm-hmm.
fibroid embolization. There are certain configurations of fibroids or certain sizes of fibroids where they're so big, as you said, one of your aunts, I had a fibroid that was so big, it looked like she was pregnant all of her life.
Yeah.
I've
Yeah.
met women like that, and I've always told them, like, fibroid embolization is a procedure where we're taking away the blood flow, and we do expect shrinkage of the fibroid, about 50 to 70% bulk to shrink of the fibroid, right? But in a fibroid that's kind of this big, the size of a
Mm-hmm.
watermelon, even with all that shrinkage, you might not have the effect you're looking for as far as the bulk of that fibroid going away. And some of those women should probably go to surgery. There's some of those women, though, that want babies in the future, and if you have a
Right.
fibroid that big and you want to go to surgery, a gynecologist would most likely have you sign a paper that says, if I'm not able to take out the fibroid safely, I will take out your uterus, right?
Yeah.
So in some of those women, they would still come to fibroid embolization first to shrink that fibroid enough so that they could go to surgery.
Hmm.
But the majority of women do not have these big giant fibroids that
Exactly.
cannot be taken care of by fibroid embolization, especially for women that are bleeding. When they come to us, we're very happy because we know that we could decrease that bleeding by 85 to 95% after fibroid embolization. It's literally night and day for women that couldn't go out, were bleeding so much, had a lot of
Exactly.
pain during their periods.
Anemia,
So the next
right?
time you see anemia,
Mm-hmm.
they have no energy. One of my first patients in Nigeria, actually, I remember this lady very vividly. She had a hemoglobin walking around of about 4.5.
Oh
That
my
was her
God.
baseline hemoglobin. She couldn't walk
Wow.
about 5 feet without sitting down because she had no energy,
Exhausted, right?
you know.
Zero.
She wanted nothing to do with surgery. So she'd been waiting for a solution to treat her fibroids without going to surgery for a while. And she just showed up in my clinic one day. A friend sent her to me, and she asked about fibroid embolization, and she signed up that day, and we did it the next day. And I mean, by the time I saw her in clinic, you just saw a completely
It's
different
like night
person.
and day, right?
Yeah, where she's running to me when she saw me, like, hey, look what I can do, doc. So it's night and day for especially women that are bleeding. When you're
Mm-hmm.
bleeding so much that you can't even go out till you come in and you now have energy. You could exercise, you could go about your life without thinking that you're going to be
Yeah.
staining your clothes all day.
Yeah. The things that we take for granted, so to speak, right? Like,
Correct.
not only is it a nuisance and an embarrassment, then you have the clinical implications of a hemoglobin of 4. Y'all, it needs to be like 9 or 10, you know?
Yes.
So 4 is like, if it gets down to 3, that person, I mean, you can just die, right? Because you need
Mm-hmm.
your hemoglobin, you need your blood to carry oxygen to the rest of your body. So
Correct.
no, I mean, what you do is amazing, and I think, what you said is not everybody, I think most people in Nigeria don't like surgery. So there's a
Mm-hmm.
lot of like, herbal medicine, which I have nothing against. So if you're taking something herbal, make sure that it's not dangerous. But if it's helping your symptoms, fine, because the truth is most people, like what we're saying, are asymptomatic. But now let's
Hmm.
just say you're not doing this herbal medicine and it's not working out, and you go to your gynecologist. It's nice that you work hand in hand with such people because a lot of times it's not like a slam dunk. For
Right.
some people it's a slam dunk. But then if you have a situation where it's like a 30-year-old woman, she wants to have children, depending on the size of the fibroid, she still may need to go to surgery. So it's
Hmm.
nice, it's a whole team kind of
Right.
effort.
Right.
So where do
So
you go ahead? Go ahead.
in America, I was used to a little bit more collaboration with
Mm-hmm.
gynecologists, where
Yes.
most gynecologists were employed by hospitals. You see a patient, and most gynecologists will see a patient and give a patient all two choices, both choices. You could go to surgery, or there's this thing called uterine fibroid embolization, where I could send you to the doctor. You could talk to them, and they could tell you about uterine fibroid embolization, and it's your choice what you want to do. In Nigeria, really, that's not the case, right? Where
Mm,
most gynecologists are not introducing the concept of uterine fibroid embolization to their patients, and a lot of gynecologists think you're in competition with them, so they don't give patients that
okay.
information. Interestingly, I've had, a few run-ins with some gynecologists who, they send you a patient, or a few times they send you a patient, they want a big chunk of whatever revenue
For the
you're getting
percentage.
from the
Wow.
from that patient. And you go, I mean, how do I give you? I mean, you're not the one doing the surgery, obviously, right? I don't come to you to ask you for a big chunk when
When
you're
I
doing
send you
surgery.
patients too,
When I
right? When
send
I
you
send you
patients,
patients,
but it's
yeah.
interesting. Gynecologists kind of have an ownership of patients. And it's just an interesting environment. So what we did is basically we started going to patients directly and giving information to patients. And even when patients come to see me, I still tell them, hey, surgery is an option. Have you talked to a gynecologist? And most
Good.
patients, though, by the time they come to see me, they've made up their mind that they do not want surgery. What they want is
Right.
uterine fibroid embolization. So they don't require a lot of convincing when they come to us. But we always try to make sure that we offer all those choices for them.
So if somebody wanted to see, because I think it's, and I think that's what we're also finding, at Lilly Women's Health in terms of like, collaborating with, I don't want to, other specialties because we're more diagnostic. We do interventions, but we don't own patients, so to speak.
Hmm. Hmm.
But because of the system in Nigeria, there's this like idea that we're competing with the people who own patients. But Hamid and I believe that nobody owns anybody, right? It's actually it's the patient's choice. They have a right to quality health and they have a right to choice. So let me know
Absolutely.
the options that are available because guess what? There are people who are going to need a GYN's services aside from
Hmm.
fibroids. So it's kind of
Hmm.
like this, like how do we get a bigger picture, amongst our colleagues to say, just because this woman is going to go for a UFI is a short term for a uterine fibroid embolization, they're going to go for a UFI, that doesn't mean your practice is going to close down,
Yes,
right?
yes,
But
yes.
even a myomectomy, meaning they're going to take that fibroid out in the muscle apart, or a
Hmm.
hysterectomy, it's not a benign thing. Meaning you're going to go on a general anesthesia, right? And people don't do very well. I know people who just went in for a routine, and
Yeah.
the woman
So,
died from there. Go ahead. I mean,
so
I'll let you talk.
if you think about the environment in Nigeria, right, where a lot of women actually, unfortunately have some complications from gynecologic surgeries,
Mm-hmm.
and have bleeding complications where they need a lot of blood transfusion. We have been doing uterine fibroid embolization for 2 years now. And again, because it's such a minimally invasive procedure, the
Yes.
complication rate is so low. We've essentially had one complication since we've been doing uterine fibroid embolization here. And that complication was a woman who had some bacteremia after uterine fibroid
Hmm.
embolization a few weeks after. We don't know if it was from an IV, we don't know what it was from, but she was successfully treated with antibiotics. But that's the only complication we've
Wow. Not
recorded
even
so
death,
far.
just
Right,
antibiotic therapy. Nice.
right. So these are patients who come into the hospital and get their procedure done, and you're able to leave by the next morning, by 8 a.m. the
That's
next morning.
amazing.
All of our patients leave by 8
That's
a.m., at the
amazing.
latest 9 a.m. the next morning, even when we
That's
do four
amazing.
embolizations in one day. So you come into the hospital, you get your embolization done. We do have some pain after embolization because the fibroids, when they're
Dying.
infarcting, they get quite angry. So there's a lot of pain after uterine fibroid embolization. So patients are kept in the hospital to give them pain medicines, but every woman is able to go home by the next morning.
That's
So you
amazing.
compare that to, having surgery, sometimes staying in the hospital 4 or 5 days after surgery and then being told to take 2, 3 months off of work, you
Wow.
know.
Yeah.
So that's the comparison is, with fibroid embolization, you could go back home by the next morning. You could be back to work. We typically tell everyone, take a week off work and go back to work the next week.
Wow, that's
And most
awesome.
women by the next week are back exercising and doing what they want to do.
That's awesome. That's awesome. No, I appreciate. So in terms of like, okay, so now if our viewers, they're gonna, for themselves personally or for people that they know. So now there's a woman who wants to get, fibroembolization. How does she contact you? How do we do the pre-op? Then she wants to know her downtime. She wants to know, certain complications, what to expect. What's your process, so to speak, for,
So, so
for
the
the layperson?
So the process, I actually always encourage most women to go to my website. It's ir.nigeria.org. There's a women's page there where we have, quite a bit of information, and we also have videos on uterine fibroid embolization. So you're kind of educated by the time you call us and say you want to explore
Nice.
uterine fibroid embolization. And that's our typical patient. Most people kind of know about uterine fibroid embolization once they come in, and we then set up a consult, an in-hospital in-office consult where I go over the procedure, I go over the risks and complications of the possible complications of the procedure, what the process is. And if you do not have imaging, sometimes I would scan myself based on the situation. I'll do an ultrasound myself sometimes. Depending on the situation, sometimes we'll get an MRI scan in a certain group of women.
Mm-hmm.
In I used to get MRI scans on all women, but we started to realize that that was just an expense that was not needed in a lot of
Okay.
women, and ultrasound is basically good enough for the information I need on most women.
Nice.
And then we do an ultrasound or an MRI. I look at the imaging and then I review the imaging with the patient and basically let them know. And most women are candidates for uterine fibroid embolization. I think 95% of women that see us
Wow.
end
That's
up going to
awesome.
uterine fibroid embolization. And because we know that after embolization, a lot of women are in a lot of pain because of the inflammation caused by the embolization, we came up with this medication regimen that we start the day before the embolization. So we
Smart.
start you on a medication regimen the day before the embolization that kind of preps up your body for the pain it's expecting. You come in for your embolization. We go through either the wrist or the groin. After the embolization, you're typically taking the process of embolization for women that are very easy or anatomy that is very easy typically takes about 30 minutes. The
Wow.
the
Look at that.
really
Wow.
the really hard ones maybe an hour 15 minutes, and that's really difficult. And again, no one's put to sleep, right? Because it's a minimally invasive procedure. We don't have to give you general anesthesia. We just give you a little bit of medicine to
That gives me
relax you
goosebumps,
on the
honestly.
table. And as I said, most of my patients are kind of talking to me through the whole process and saying,
Mm-hmm.
"Hey, where's your catheter now? What's that?" And I'm
Wow.
describing anatomy to them in their body. And we get through the embolization. You're taken back to the recovery bed or the recovery space, and we give you IV medicines through the night as needed for pain. And as I said, most people go home by the next day. And we also give you medicines to go home with for 3 or 4 days after the embolization, because you still have some cramps, like you've had a bad period for a few days, and there's something called post-embolization syndrome, where you just feel generally tired
Mm-hmm.
for a couple of days, and most women expect that. Some women are very resilient, though. I've seen a lot of hardworking women that come in, had an embolization done. I go to their room 3 hours later, and they're on their computer working already, and I go, "What are you
You're
doing?"
like,
I feel disrespected, like I didn't do anything to you.
they ready to
Uh,
jet.
yes, yeah, you know. So you also have that those group of women, but
Nice.
a lot of people are able to get back on their feet very quickly and go back to regular life.
Yeah, and I mean it's amazing. 30 minutes for like straightforward, an hour and a half for complications. And so
Hmm.
far your track record has just been amazing. I mean, I think we need to like shout this, you know what I mean, on the airways because think about it, 200 million people in Nigeria. How many people are female? How many people have, we're talking millions of women who have symptomatic fibroids, right? Even though most is
Correct.
asymptomatic, we got millions there. So we really have to like make a lot of noise about this. So if a patient, so I know you currently operate mostly out of I want to say Eurocare, First Cardiology,
Correct.
and in Abuja.
Yes. So we've not so we were actually supposed to start our operations in Abuja just the week where, everything shut down because of COVID. So
Yeah.
we'd seen a few patients. I was supposed to go back to do the procedures, and that just did not happen. So the airports are being opened up again next
Okay.
week, and I'm thinking about going to Abuja the
Nice.
upper week to get those procedures done. But we typically operate mostly out of Eurocare, multi-specialty hospital in Victoria Island, and First Cardiology clinics in Ikoyi, and those are my two
Nice.
primary sites in Lagos.
Nice.
There's a question here saying, does the number of fibroids matter?
I
So
was
that's the
about to, yeah.
beauty. That's the
Mm-hmm.
beauty of embolization is it really doesn't
Right.
matter how many fibroids you have because you have one uterine artery on both sides, and as long as we're able to get into both uterine arteries to embolize them, and so far we're able to get into every uterine artery 100% of the time. If we embolize them, we could treat every fibroid in the uterus at the same time. This is if you compare this to myomectomy, for example, when you go in to do a myomectomy, you could only remove, a few
The
fibroids at one
largest,
time,
biggest
right?
ones.
Right.
Mm-hmm.
You can't remove all the small ones. So with uterine fibroid embolizations, all the fibroids are definitely treated at the same time.
No, that's amazing. And I think the next thing that people always want to know, is cost. I mean,
Yes.
we know that the lifestyle changes are revolutionary and amazing. What's the cost, for this
So
service?
so it depends. I'm thinking off my head now. So I
Yeah, just
think between the
average,
two
yeah.
hospitals, I would say because especially with COVID and the dollar going up, the average
Mm-hmm.
now is probably about 1.7,
Mm-hmm.
and which includes the evaluation, the procedure, and a 2 week and a 3 month follow up.
Okay, so 1.7 million for everything, right?
Correct.
And now this is going to end up being life changing. And somebody asked, does it come back after? So after, I spent 1.7 million, my life has changed.
Mhm.
I'm going on about my business. Maybe I now have a baby, I have less pain. Does the fibroid go back again?
So that's a big question. And let's say you have a surgery, you have a myomectomy, or you have uterine fibroid embolization. So when you have a myomectomy, they remove all or a few of the fibroids. When you have uterine fibroid embolization, we embolize all of the fibroids that are present in your uterus at that time. Now let's
Mm-hmm.
paint the scenario of a 30-year-old woman. A 30-year-old woman has about 20 to 25 years before she reaches menopause, right?
Right.
That means even though all of the fibroids in your uterus were treated when you were 30, you
Mm-hmm.
still have 25 years of hormones raging in your body, so you could grow new fibroids in
Make
that
more,
period of
right?
time. So a 35-year-old woman has maybe 15 years left, before she reaches menopause. So the closer you are to fibroids in the right? But what I always tell most women, because the average woman that gets uterine fibroid embolization is around 38, and that woman probably has an average of 12 years before menopause, the
Mm-hmm.
chances that you would have fibroids that would be symptomatic again is less than 20% if that's your age group.
Yeah, and that makes sense because at least then you're also providing this like 10 to 20-year window where people are not like, having the heavy bleeding, fancy word is menorrhagia, where they just
Mhm.
cannot even have a life. So at least you're kind of like giving them this like space before getting to menopause. And of
Correct.
course, if you're a younger woman who the fibroids is causing you to have infertility issues, then you understand that, let's shrink it to see if I can, reproduce. But then if it comes
Right.
back again, we'll deal with it. And I
Right.
know a big question people always ask is, how do you prevent it? I mean, it's one of those things that you can't really prevent it. It could be genetically based. We see it mostly
Mhm.
in Black women, but there is like an association with being overweight, with
Correct.
fibroid formation. So I think as with all things, diet, exercise, just living a healthy lifestyle, I think it can help to see how we can prevent fibroids, but I doubt that very much. Um, but I really appreciate, what you're offering. Another question I think people may be interested because I'm getting a lot of questions on
Mhm.
both my WhatsApp and like other multiple phones. Is people really want this service? They're excited that we're talking about this. How are you handling COVID? So is this something that they should wait? People are like, should I
So,
wait till after
so,
COVID?
so
How are we doing with
interestingly,
COVID?
so that's a very good question. So when COVID came, I basically completely shut down my elective services, which fibroid embolization, prostate artery embolization were, elective services, meaning people could wait. So for about
Right.
a month to 5 weeks or so, we did no fibroid embolization. We only offered emergency services for people that were bleeding or people with cancer that couldn't wait. And then we basically went through a few phases with COVID. The first phase was the panic phase, I call it, where we just shut down everything. I put my employees at home. I said no one should come to work, and I basically just did emergency services. And then we started gradually opening up, and we put in this policy in the hospital where comes into the hospital now to get a procedure done or to get admitted gets tested for COVID.
Nice.
So we have a rapid antigen test where the day of or the morning of your procedure, you get a COVID test so that
Perfect.
anyone in the hospital within that space we know is COVID negative. by the time they come in.
Perfect.
And that's how we ran the service safely now. And the staff is screened every day with temperatures twice a day. So we
Nice.
have identified one staff member at some point who was positive for COVID, and we, put off the rotation for that period of time. So we have
Nice.
strict policies now that have kept people safe. What we've come to realize is COVID is here for a long time.
Oh yeah.
It's not going.
It's here
It's
to
not going
stay.
anywhere anytime soon, and we need to kind of learn to live with COVID, and which is what we've started to do.
And I think that's an important point for all healthcare services, just to let the people at home know, COVID is here to stay, and we're realizing that, it's actually starting to hurt other things. So if you have appendicitis that's emergent, people are not showing up to the hospital. People are having a heart attack and not calling 911, here in the US, or, seeking care in Nigeria. So they're having more complications and unfortunately deaths
Hmm.
from other healthcare issues because of the whole COVID. Cancer patients, for almost like what 2-3 months now, weren't getting their care. So the whole healthcare system is like, hey, look, we know that it's here to stay. We're very good at trying to like mitigate infection with the PPEs, the gloves, the
Hmm.
masks
Hmm.
for
Hmm.
us, for the patients, because we have to go on with our lives. And like breast cancer. So I'm a breast cancer physician. So here in the US, everybody's wearing a mask at our healthcare institution because you're realizing people are not getting screened. So if you have a woman
Yes.
with like a very aggressive cancer, it's just growing. There's some
Right.
cancers that can grow very aggressively in a short amount of time. So you're saying,
Yes.
what's the risks versus benefit? So we just kind of like take our precautions, sanitize, wash our hands, wear
Hmm.
masks, surgical masks in a healthcare institution, cloth masks if that's what you can afford, out there in public, and we just have to live our lives and just keep moving on. So I'm glad to know that, things are ramping up and everything. Um,
Absolutely.
so we're getting different questions. So, because, we're at the 48-minute mark, and, Instagram's going to just shut us down. Um, and saying, do you get regular periods after the UFI? Um,
Yeah,
Go ahead.
so so UFI does not alter the regularity of your periods. You still get regular periods. They're just much, much lighter than you had when you had a lot of heavy bleeding.
Exactly. And then someone is asking, when you get to menopause, what happens to the fibroids? Well, the idea is because you're no longer having that hormonal situation of like, where your estrogen and progesterone are increasing every month during your cycle, the idea is it will get smaller and smaller. And you will
Correct.
not be having that issue of the heavy periods. But then if you're having a body image issue where it's caused your body to be bigger, your belly to be bigger, or if you're having pain, that's another reason why people seek medical intervention for it. But yeah, Dr. Hamid, thank you so much for
But
this. Go
but
ahead. Did I cut you off? Go ahead.
one other thing we've noticed in Nigeria is a lot of women actually do not go into menopause until really late. So
See?
as opposed to the Western world where women typically go into menopause in 49, 50, the average age here is 55. So you have women who
See?
are still have symptoms from their fibroids for a long period of time and does not go away as expected.
Yeah. And somebody asked, which facility do you use in Abuja? I'll let you answer that.
So we're currently collaborating with NISA Premier Hospital in Abuja. There's another center that should be coming up very shortly. Again, we'll announce that when that happens.
Okay. All right. Perfect. So we have other questions. We'll type that up and then we'll post it on our page. Thank you so much for coming on to the
Thank
show.
you for having
Hopefully
me.
we'll have you on for, other things because I think interventional radiology is very cool. It's something I was going to go into myself, but I topped out. Uh,
Smart.
so no, so I'm very proud of you. And like we said earlier, Hamid is honestly, probably the only interventional radiologist full-fledged in the whole of Nigeria. So he does other things other than uterine embolization. So if you need anything interventional related, if you have any questions, go to IR Doc Nigeria. You can also connect with us at Lilly Women's Health. We really care about our people. We care about Africa. We certainly believe Black Lives Matter. We believe that you deserve quality health care no matter where you live, which is why we have put our time, our money, our efforts, our family to serve you, so to speak. So any questions you
Absolutely.
have on anything, we're here to serve. And you're gonna definitely see me and him back again, on Coffee with Lily and probably on his platform. So
Yes,
thank you so
yes.
much.
Thank
Everyone,
you.
stay safe. Please wear your mask when you go outside. I'm sure y'all have seen that graph, fear of COVID. when COVID was like not really here, and now that COVID is everywhere, people are no longer afraid. I don't want
Yes,
you to be
yes, yes. That's
afraid.
what we've
You
seen.
need your sanitizer. You need your mask. Please
Yes, yes,
put your mask
absolutely.
on, wash your hands, social distance. I know we're all wanting to get back to life as usual. We're feeling comfortable. Just take the right precautions and we'll get through this. So
Absolutely.
thank you so
All
much
right.
for
Take
being
care.
on the show with us. You take care.
All right. Thank you, Lily. Take care, everyone.
Okay, bye.
Bye-bye.
So there you have it. That was amazing. I thought that was a great informative talk. Uh, keep keep on the space. We're gonna, be here with Coffee with Lily. We're gonna talk about different things: healthcare, lifestyle, anything goes. Relationships. We want to spill the beans. We want to start talking. We want to start relating. We want to start communicating. So nice to see y'all. You can stay till it goes off, and I just want to play our anthem one last time. Yeah, nice to see y'all. Thank you so much for joining. Thank you, thank you. Thank you, Dora Healthcare. I see you. Penny Queen. Hello, Penny Queen. Learn Skincare Africa. Thank you so much for joining. Thank you. And we'll post everything on our Instagram page. The video will be available on our YouTube channel, Lilly Health TV, and also on IGTV Live. Send any topic that you want us to talk about, any information you want, anything you'd like us to have speakers on about. Send it to our DM us on Instagram, Facebook, or email. Check out our breast services site at www.lillyhealth.com. I really enjoyed it. I'm going to miss y'all. Okay? Take care, okay? Stay safe. Mwah.